from KDHE, the vaccine distribution video from Liz Dunn. So Liz, go ahead and take it away.
Actually, I think, ma'am, this is Dr. Lee Norman. I think we were expecting for me to give a briefing with a slide deck.
Do we have that?
It's, I know we've sent the slide deck over earlier.
Okay, all right. Secretary Norman, go ahead then, thank you.
Okay, very good, thank you. And thank you for the invitation to speak with you today. I'm in my office by myself, unmasked, so that hopefully you can hear me articulate words clearly. I do have in a separate room, I've got some of our subject matter experts in case there's a question or two that I can't answer. With your permission, of course, I would invite them to answer it, to clarify if need be. Yes, committee and chair, thank you very much. This is Lee Norman, and I'm happy to go through the vaccination methodology and kind of where we are in the COVID-19 vaccine. I did want to tee it up briefly, though, just to set the context. This has been an immensely complicated enterprise, and I think you'll see that. The slide deck that I'm going to speak from is, I will hit just the high points from it, but it'll give you an idea of the complexity of this operation throughout the world, but especially, of course, here in Kansas. This has been we've been in the incident command for over a year. We're probably about 57 or 58 weeks into our 24/7, 365 rhythm with this pandemic, and it has had a lot of moving parts. But I wanted to look back just ever so briefly. This has been many waves of a crisis. This hasn't just been one crisis. This has been many waves, both from an illness perspective, economic, and otherwise. But it's been a story of shortages. And when you think back, remember a year ago, we had PPE, protective equipment shortages, and testing, reagent, testing platform shortages, case investigators, contact tracers, shortage, hospital bed capacity with hospital overruns, staffing shortages of personnel because there's a lot of people home sick, isolated and quarantined. The antibodies, the therapeutics were in short supply, and the ability to route patients throughout the state, what we call mission control, was not built out yet. But we've managed to do well with all those things, and those things are no longer in short supply. Talk about vaccine in just a moment. I did want to give you today's updated numbers just to give you a sense of the positive direction we're going. You'll recall that we've had 1,000 to 2,000 new cases a day for months on end, really since November. And today, since Friday morning till this morning, 883 new cases in the state of Kansas. That's less than 300 a day. Now, there may have been a little bit of reporting shortages just because of the cold weather and whatnot, but still, that's a very positive trend line. The number of new cases, the number of hospitalizations, and the number of deaths is going down in the state of Kansas. We had, and I take every death seriously, of course, 29 deaths since Friday for 3 days is the lowest we've had. And all that is on our website, of course. It talks about the favorable trend lines. And one other one I think is worth mentioning is the number of positive tests. We've increased testing dramatically. We've had right at 2.5 million Kansans have been tested, and we have more testing capacity now than ever. It's been a free test for a long time now. And it's about 5.1% statewide. Remember, we were up in 16, 18% test positivity rate, but now we're at about 5%. And that's going to have a very favorable impact on the reduction on the disease spread, for example. Okay, what I want to do now is I want to share a slide deck with you. So let me just see, share file. Madam Chair, can you see that?
I cannot.
Okay, let me do it a different way because I do want to bring this up. Okay. Sorry for the delay. Every one of these programs is a little bit different. Okay, it's loading, I think, ma'am. One of the things I want to do today is, can you see that?
Yes, we can see that. Thank you.
Oh, very good. Okay, progress.
Okay, well, hang on, I can see it on mine. Are you able to pull that up?
Well, okay, let's see. Maybe what we'll do is have your person run the slide deck, your host. Would you like to do that?
Hang on just a second, me.
Okay. Because I can see it and you can see it. How are we doing on your end?
Well, I can still see it. We are trying to get it to be shared.
Okay. I can, okay.
They're working on it. Just a second.
Okay. But well, I'll tell you what, do you guys have the electronic slides in front of you? We could just walk through it and I can talk through it. How do I stop sharing?
Okay, I think we can see it now, and I think I'm going to have to scroll through the through your
Hold on.
slides. So let me know when you need to scroll, and I can scroll through.
Okay, there we go. Thank you. So you're running it now, ma'am?
Yes, I am.
Okay, that's great. Thanks. Sorry for the delay, people. Yeah, and you can hear me and you can see slides. We're in good shape. Okay, next slide, please. Thank you. This is slide number 2. And the one thing I wanted to point out on here is that website, www.kansasvaccine.gov. That is a treasure trove of information about the vaccine in the state of Kansas. And I'm going to show you a number of slides that come directly from that. It's real-time information. You'll find it to be terrifically helpful. Next slide, please. How are we doing in the state of Kansas? We're going to get to some numbers in a minute, but one of the things I think I can assure you, whether it's in Lindsborg or in Sedgwick, where the big arena is, or throughout the rural and urban counties, we're putting a lot of vaccine into hundreds of thousands of Kansans' arms. And it's very gratifying. You see people in tears, you see people high-fiving virtually, and it has really been a boost for morale through the state, especially in the healthcare workers, the elderly population, et cetera. I think a general sense of relief in coming to the state. There's been a few speed bumps along the way. We're going to talk about those, but I wanted to first and foremost say we get lots of kind of communications of gratitude. Next slide, please. If you look in the upper right-hand corner there, that says 17 February. So these data are already a little old. If you look on the left side, Kansas COVID-19 vaccination overview, instead of where it says 456,093 doses having been given, that's over 500,000 now, 509,332. If you look in that lower left one, instead of 581,000, that's 645,000 doses that have been delivered to the state of Kansas. So that's been very gratifying, with over 11% now of our populace having been vaccinated. Still have a long ways to go. I would like to make a note also that 1 out of 10 Kansans have actually had COVID-19. And we don't believe that the immunity from the COVID-19 infection is going to be a very durable or lasting immunity, but and those people should get vaccinated again. I should say they should be vaccinated, but the numbers are going in the right direction. This represents 79% of the vaccine that has come to the state is now, I should say that's the lowest number. It's, I'm sure, greater than that now. We've had some data issues about interfacing between the vaccinating sites and our immunization tracking program. But 79% of the numbers I just gave you have been vaccinated into people's arms at this point. Next slide, please. This is a very encouraging slide with things going the right direction. Again, this is 19th of February, but you can see back from the even earlier than the January 31st lower left-hand side of the slide there, 77,000 doses a week coming into the states. Now we're forecasting 114 and then 121. We never know exactly the numbers until we look back at a week and say this is how many doses we received. The federal government has been pretty dependable, but not perfect. You'll recall that earlier on we were at 45,000 doses, so we've actually come a long ways. The TBDs that you see at the top of those histograms are what you see on the right there, the Federal Retail Pharmacy Program. We're starting to get, the feds are sending directly to pharmacies. In the first week, we had about 85 pharmacies that were in direct receipt of the vaccine. That's a number that we really don't have good visibility on until we get into the week and find out what those numbers. But I think what you can see there is that it's a very positive trend line. On the right-hand side over there, you'll see that phase one, the 220,000 residents of long-term care and healthcare workers were phase one. We're essentially through with phase one. We'll talk a little bit more about long-term care, but have done, I think, a nice job. All of the long-term care residents haven't chosen to be vaccinated. We're about 88% now that have, and the healthcare workers, same numbers, and the people who work in long-term care facilities, a little bit lower uptake for reasons that are not clear, but more in the 65-68% range of the long-term care workers are being vaccinated, are choosing to be vaccinated. They've all had it offered to them. We are now in phase two of the prioritization schedule. The ones on the right there, and you've seen, of course, in the press, age 65, critical high contact workers, and those that live in congregate settings. Those are all defined, by the way, in on our website, and I'll show you that in a minute. Next slide, please. This is a busy slide, mostly for you to read on your own, but I wanted to point out that we have two vaccines at the current time, Pfizer and Moderna. Pfizer's a 2-dose series, followed with 3 weeks or more between. Moderna is a 2-dose series with a 4-week or more interval between the two. Johnson & Johnson is applying for an EUA, emergency use authorization. It is a one-shot series, a little easier to transport without having to have all the cold management. The Pfizer is particularly finicky, has to be transported at 70 degrees below 0 centigrade. And that's not a type of refrigerator or freezer system that most places have. But we're still getting a lot of Pfizer in the door. And by the way, these 2 vaccines have been excellent. High 95% response rate in people that have 2 vaccines. Yeah, a little bit of side effect with maybe aches and chills and those kind of things, soreness at the site, but people have tolerated it very well globally. Johnson & Johnson, we've not seen all the clinical study results yet, but I think will probably not be quite as efficacious, but still at 70, 75% is a very successful vaccine. Keeping in mind that even when a vaccine doesn't prevent a person from getting the illness, it prevents them from having hospitalization, severe illness, and death. And that's a laudable goal too. Next slide, please. Busy slide, but I want you to pay attention. I mean, you can read it on your own, but to just the top line. One of the things that I'm not sure if it was a brilliance in marketing or not to call this Operation Warp Speed when it comes to injecting something into people's bodies. On the one hand, we like to move things quickly when it's a pandemic and a global emergency like we've been living through. But also warp speed, people, I think some people say, well, it makes me a little nervous, the fact that something's moving so quickly. Do I really want to get something that's moving that quickly? The warp speed about this isn't the research that's gone into this. It's been going on for a decade, ever since SARS back in 2003, 2004. What's been the warp speed is the production and distribution has been at a, I think, only mimicking or only matched by the Berlin airlift after World War II. I mean, this has been a spectacularly fast manufacture and distribution. I bring this up because I think U.S. leaders are such a pivotal role, I think, in spreading the word about vaccines. These are safe vaccines with great deal of not only research, but of the tens of millions of doses that have already gone into people just in our country. And we've had a very good safety profile. Next slide, please. This is just a brief description of how the vaccine comes into the state of Kansas. If you look in the upper left there, the vaccine manufacturers, there's the 4 that are kind of the 2 we're getting now, plus the next 2 or so lead horse candidates for the next vaccines. Essentially, what they do is that the vaccine pushes it out to a distributor right in the middle, and then it goes to either a depot or this administration sites like pharmacies, long-term care providers, et cetera. But a piece that can't be forgotten is that, you know, if we have, we're giving millions of doses over these next months into Kansas, it takes a lot of syringes, a lot of alcohol swabs, a lot of Band-Aids and the like. That's why that bottom left-hand side is real critical, and the Operation Warp Speed marries up the kits that have syringes and the like with the vaccine, which by the way is free. The vaccine is free to every cancer, to every every person that gets it. And then it goes along the same distribution channels to the vaccination sites. As trivial as you may think that a syringe is, we found out very early on, you maybe have read this, that instead of getting just 5 doses out of a Pfizer vial, we're able to get 6 or even a 7th dose. And that, when you think about 1/6 or 1/7 of the total vaccine supply, is a heck of a lot of vaccine. And we found out in week 1, day 1, hour 1, that a 6th dose pulled, and we gave the guidance from the very start, yes, go ahead and use that vaccine. I'm glad we did, because we've depended on it. But then we had a week where the syringes came out that didn't allow for that 6th or 7th dose. So something as trivial as what brand of syringe depends on the amount of what we call dead space in the barrel of a syringe, reduced our vaccine supply by a 1/6 from the Pfizer. We fixed it, and we got the right ones. So something as you would think would be ostensibly as straightforward as distribution is always a challenge. And you saw last week, I didn't mention it yet, but we didn't get vaccine last week because the people that pack it and pick it and put it in boxes and freeze it and put it into UPS and FedEx, they couldn't get the job done because of the weather. So we got almost no vaccine last week, and it's pushed all into this week. So a little bit of a slowdown mode, but the vaccinating sites seem to be responding. Next slide, please. how are vaccines currently being allocated? On the right-hand side, you can see the allocation criteria. It's essentially the thing that drives more than anything else, and it won't surprise you, is population size. The population size is per capita allocations is what drives vaccine to particular counties. There is a small factor called the Social Vulnerability Index. You see bullet number 2, CDC. The CDC ranks every county for how healthy or how sick it is. And there are 17 counties, and it could be due to poverty, it could be due to ethnic mix or transportation limitations and the like. But we have a handful of counties in the state of Kansas with a high social vulnerability index. There's a little bit of a modifier in terms of their dosage allocation. There's been some fine tuning with teachers. You've seen over these, we've been vaccinating teachers over the last couple of weeks, and in a much increased fashion over these next few weeks. We'd like to feel like we can get the teachers in the state of Kansas, the K-12s, vaccinated in the next few weeks, so that when they come back into classroom in March, they'll be protected. There's a little bit of nuances. I'm not going to bore you with it, but Moderna comes in 100 dose packaging, and we can't break them up and send 50 to one county or 75 to another. So you may see on our ks.gov, there's a spreadsheet up there that shows the ballot allocations every week. Why would somebody get 100 this week and none last week, or 100 last week and none this week? Is because some just want 50 doses a week, and we'll send them a double dose one time and none the next. Next slide, please. You can't give vaccine without having providers, and we've got a lot of them. Most of them don't have vaccine yet, just because we have not had enough vaccine coming into the state. Doesn't make any sense to turn on a vaccinating site if they don't have vaccine. We started off with back in December with about 350 vaccinating sites. Mostly they were local health departments, hospitals, and federally qualified health centers. Think of them as the safety net clinics. We now, as you see on the bottom left, there are over 1,000 vaccinating sites enrolled. And on the lower right side, you see there what type of providers are those: pharmacy, medical practices, hospitals, et cetera. The counties where things have gone the smoothest is where, because we've depended heavily, local health departments have always been in the game of vaccinating. That's what local health departments do. And we've relied heavily on the local health departments working with hospitals and other providers, clinics, so that when they have an excess at the local health department, they push them on out. It's caused a little bit of I won't say a nightmare, but it's caused a little bit of a problem with tracking where those doses have gone and who they've gotten into. That we are undergoing now, I would say, a very strenuous program to clean up our data, because I mentioned earlier, 79% of the doses, according to CDC, are getting into Kansas. Well, we know it's much more than that, and we need to clean up the data, despite the difficulties. And I won't get into it too deeply, but there's this thing called HL7 interface where one system can talk to another to allow for the movement of data. There's some HL7 interface issues, but we're in the process of doing a workaround to clean it up and then to fix it. Next slide, please. This is a very pivotal slide, and because the information on it is critical. How and where did the prioritization schedule come from? Phase 1, 2, 3, 4, 5, or the CDC had 1A, 1B, 1C, et cetera. That confused a lot of people. So we went to 1, 2, 3, 4, 5. We're in phase 2 now. Phase 2 is the biggest number of people, probably around 1 million. Kansans are in phase 2. This is what the decisions were made upon as to what was in 1, what was in 2, what's in 3, et cetera. So you see number 1 there, above proximity, is clinical outcomes and death. Who is the most likely? Who is the most likely to acquire the illness, have severe illness, and die? That's obviously why health, long-term care facility residents, for example, were included. They are the most vulnerable, and the elderly in general, much the highest ones. The second one is proximity. residents and staff are less than 6 feet away from each other, and they can't do much about that. They are therefore much more likely to need the vaccine. A good example might be a preschool teacher versus a college professor, because we've gotten inquiries about why are college professors not included as same as K through 12. And the reason is college professors can distance themselves, and as opposed to preschool teachers, which you can't keep yourself 6 weeks away from preschool kids. Ditto that for type of contact. College professors less likely to be exposed to droplets, shared surfaces, and common items, where a preschool teacher is highly likely to, kids are sneezing and wiping their noses on your sleeve and everything all the time. You can't control that. You can try. Contact duration, obviously settings like nursing homes, you live there, not there for 10 minutes or less, you live there. And finally, and this is a great example for this last one, how do you implement protective measures? Meatpacking industry is a great example of that. And you saw where there was just always continuous outbreaks in meatpacking, but big changes were done in the modification of the space indoors. It's confined, but you can put up plexiglass, you can change your break schedule and the like, test people when they come and go, you can take their temperatures and the like. So these are 5 things that drove the prioritization schedule. Did we make this up out of thin air? No. If you look at the very small print at the bottom, DHS, Department of Homeland Security, it was important to us to make sure that what are the critical infrastructure things that if it were decimated with illness, that we would be hard pressed. Got a little bit of controversy over, for example, wastewater and drinking water workers throughout the state of Kansas. Look at Texas. When you take out the water supply, and if we didn't have people to run the wastewater and drinking supply of water in the state of Kansas, I rest my case in terms of why wastewater and drinking water workers are prioritized. They are public health workers that are critical. Department of Homeland Security helped us think through that, as did the CDC, and quite importantly, 2 other groups. The Advisory Committee on Immunization Practices, which look at evidence. They don't, it's not a popularity contest, they look at evidence. And then finally, we had our own COVID-19 advisory committee that, weighed in on who should be in what priority groups. And there are disability communities, tribal groups, ethnic and racial minorities, commerce, science, medical bioethicists. And it's still a group that's ongoing and looking in case we ever need to modify or make any changes in our prioritization schedule. Sorry to spend so much time on that one, but it's so critically important that people understand the discipline that went into this. Next slide, please. This is right off our website. I'm not going to read it to you. It's basically the depiction of what I've said. We're in phase 2. Now, I'll be the first to admit that the late January, March, late April, mid-May down at the bottom, or June, that depends on a number of things. One is how much vaccine. We haven't changed it yet, but it depends on how much vaccine comes into the state. And then secondly, of course, how many people choose to get it. If 90% uptake, that's a different ballgame than if it's 75%, as you can well imagine. Next slide, please. I wanted to point, sorry about that, maybe one up. There we go, thank you. It's the same thing again. If you look in the dark blue box, one of the things that just came online today is, you see that second bullet that says National CDC Vaccine Finder in Development? That is now available and public facing. The Vaccine Finder at CDC, you can go in and see what where is vaccine in your state. I pointed out that we have a lot of vaccinating sites, and on our ks.gov map, it depicts where are those sites in each county that are registered as providers, and then it provides the information like websites, telephone numbers, et cetera, to register. What the National CDC Vaccine Finder assists with is it's turned on today. As a matter of fact, it's not new. For example, if you said I'm going to, someplace and need to have yellow fever vaccine, you can go into Vaccine Finder and find out who has in the state of Kansas has yellow fever vaccine. Ditto that for COVID-19. to be honest with you, it just turned on today and I haven't looked at the public facing yet, but that's going to be something you're going to be hearing more about to keep an eye out for. It'll augment where the vaccine is in every state. And then on our website, we can give you the additional information about websites and phone numbers, so how to get registered. Next slide, please. I mentioned about our website that has the information, and that's where it's called Find My Vaccine tool. So you go in and to again, on the upper right side, kansasvaccine.gov/etc. Find My Vaccine. And this thing will pop up. You put in your zip code, put in how much distance from your zip code you're willing to cast a net, and it depicts for you where the sites are that are vaccinating sites. Next slide. 156 locations, by the way, are currently listed. 103 have received vaccines. 53 have not yet had vaccines available. Pretty straightforward. You know, for all the falderall about this, when people go in, they get a vaccine and they sit for 15 minutes and monitor for any side effects and they leave. And it's the vaccination itself, it can be a little anticlimactic after the build up to it. But it's pretty straightforward. You get the vaccine after just a couple brief questions and filling out a form. We monitor you for 15 minutes if you're just a routine person. And if you've had a previous allergic reaction, we monitor you a little longer. Come back again. At the time you get the first vaccine, you make your appointment for the second vaccine, either 3 weeks or 4 weeks or more later, but 3 or 4 weeks. And then the thing that's really important to remember is that, at least for a while, and probably for a fair amount of time, wear a mask, avoid close contact, and get tested, because there's still a lot of COVID-19 out there. Having the vaccine may prevent you, and likely will prevent you from getting the illness, but it may not prevent you from being able to spread it if you should happen to be exposed to somebody. We're finding that out all the time, getting more information, because somebody's going to ask me a question, and I'm going to about when can we go back to life as normal, and I'm going to answer something like, once about 85–90% of people have either been ill with it or preferably vaccinated, the number of cases have dropped dramatically, then we might at that time start talking about, yay, good for herd immunity, and we can start returning back to normal. I think what we're going to see is more kind of relaxation on some of the things that have left us over this period of time. But for now, keep doing the good public health measures. Next slide, please. And we only have about 5 more to go, or 6. How do we track? And this has been this has probably been the most frustrating thing throughout this whole vaccine journey, and that is monitoring the data. The providers, to sign up as a provider, you have to be able to register in the state system, the Kansas. It's called WebIZ, as in immunization, WebIZ state system. By the way, as per the bottom one, many of you will remember this as legislators, the WebIZ is a statute mandated reporting system for tracking immunizations. And then, because once it gets into WebIZ, then it goes up into to the CDC, and that gets reported on their COVID tracker website. And then secondly, the providers have to be able to register every day on the vaccine finder. That's the federal system I mentioned earlier. That's basically an inventory system, so we know where the vaccine is available. The training is quite easy for WebIZ. It's not a big barrier to people that want to serve as vaccinating sites, but it is sensitive because WebIZ, think of it as a protected health information, and think of it as a medical record. So we want to make sure that everybody's fully trained, so that even though it's just talking about the immunizations and some of the things around that, it's confidential information, and we make sure that the providers understand that and sign a confidentiality agreement. Next slide, please. Excuse me. One of the things I mentioned is that the CDC, if you look in the box over there, the CDC COVID data tracker, it has all the states compared for how many doses per 100,000 people. That was on the 19th. Today is what, the 22nd, and instead of 16,020, we're at 17,483. So it creeps up every day, depending on the amount of vaccine coming into the state. Ours is going to go up rather dramatically once I've talked, and this is the last thing I'm going to talk about data unless there's questions. When we do this workaround, we get the files sent to us of the ones that are not registered. We're going to have an uptick, I think, pretty dramatically in our amount of vaccine administered per 100,000 people. But until that fix is there, we don't rest because we need to fix that. Okay, next slide, please. Home stretch. Talk about three things ever so briefly. Next slide, please. I already talked about this. On the left side that's the administration rate starting back at right after Christmas is now up to, again, that's 19 February. We're at 79%. So our curve is going the right way on the number of shots getting into people's arms. This root cause of this administration gap, that is the administration of the gap of the vaccine, I've already talked about with a workaround today, starting today. We're querying every health department every day as to the amount of vaccine that they have, because we need to know, is it getting into people's arms, and then to find out what we call a flat file, a spreadsheet, essentially, to make sure that we can account for every single dose in the state of Kansas. Next slide. This shows 79% has been allocated, the doses delivered, and then you can just see that cascading, the number reported is administered. One of the things we're tracking real carefully is the doses delivered and reported in inventory on the right side. I believe that this data issue will shrink that dramatically. For example, I believe that has already come down. I don't remember what the date of this particular graphic is, but it's come down rather dramatically. That shows 121,000 doses in inventory, and some of that is normal. In other words, if a county got 6,000 doses yesterday, for example, and you measure it today, they will not have pushed those out yet. Also, there's a boost dose, and then there's a prime dose, which is the first one, and then a boost dose. It's normal to have in your freezers your booster dose for those people that have had their first one, and they need to get their second one. So some inventories is fine, but we don't want people holding on to it for too long of a period of time, and most especially, we need to monitor to make sure it's getting into people's arms appropriately. Next slide, which is the next to last one, pleased to tell you. The long-term care, the residents, 49,000. I think this is probably a little bit old, but we now know that of the residents, 88% of the residents have been vaccinated, at least with their first dose. As you can see there's the prime and boost doses. The staff, a lower uptake, 68% have chosen to be vaccinated. And then finally, that's the total. It was a bit of a challenge, I'll say. We have 680 or so, and that may not be exactly right, but something like that. CMS, regulated and licensed facilities, long-term care facilities in the state. We knew where those were, but it's been a little bit of a challenge to find out, because there's a lot of what we call, and you see on the right-hand side, the number of orphaned long-term care facilities, right, not included. Those are ones that are licensed, that are not licensed by CMS. But as you see there, KDEDS and KDHE have worked together to find these orphan facilities, because those are on us. The federal program on the left that came, and you may have seen this, came through CVS and Walgreens. That wasn't vaccine. It's our vaccine to the state of Kansas, but it went directly from the feds to the right to the long-term care, right to CVS and Walgreens for administration. That is one of the reasons, if you ask me, why is our vaccine going up in the state? We're getting more of that for our use on the state side, because the long-term care people are being vaccinated. So what this on the right side shows here is that we have very few facilities that are continue to be orphaned. And I think it's less than the 27 number. We're still trying to find every one of those, working with agencies on area agencies on aging and the like, local health departments, to find out where every one of those is. Okay, finally, the last slide. This is just started a couple weeks ago, the Federal Retail Pharmacy Partnership. That is new. It's been in the works for a while. The Fed's sending directly to retail pharmacies. And if you look kind of at the first paragraph there, we talk about the week of the 8th, Walmart, Dillon's, Kroger, ABC, and there's footnotes about these, Cardinal, et cetera. Those are the pharmacies that are sprinkled around the state that, and it's a small number compared to what we eventually will have. So the ones on the right there, those dots, because every a pharmacy may be the only kind of quote care provider unquote in some of the communities in some of the counties. Eventually there'll be a lot more dots, but at 2,000 doses per pharmacy, for example, there was not enough to go around. If you look under the map, the light green color, one of them that's really important is CPESN. It's a consortium of independent pharmacies. So when you think about not the big box stores, the Walmarts, et cetera, or even the chains like CVS and Walgreens, the CPESN is one that is really important to the state of Kansas because they're the little guys and that serve a real important need in the communities. We really want to help them. We want them all to be successful, but they're an important group to us also. So I guess I'm done with the slides unless you want to go back and look at something in particular. I think the program direction is going the right way. We hear about a slow rollout into Kansas. I don't think the rollout has been slow at all. The measuring of every administered dose has been a little bit slow. We are in the process of fixing that now, but we haven't wasted vaccine. It's not languishing on shelves, and nothing is of more importance to us than picking the right population and vaccinating people. So with that, ma'am, I'll turn it back to you for any questions you might have.
Mr. Secretary, questions from the committee? Representative Vaughn.
Thank you, Madam Chair, and thank you, Mr. Secretary, Dr. Norman. That was a great presentation. I always learn something new when I hear you speak. Yeah, so I just had a question. I was listening to NPR this morning, and they were talking about West Virginia's success in distributing their vaccines and highlighted their hotline that they have to answer questions or FAQs about when they can access the vaccine, where to access the vaccine, all those sorts of things. I was just wondering if that's something we'd considered and what your thoughts were on that.
Yeah, we actually have a hotline and a whole phone bank just for that. Matter of fact, today we're bringing on another dozen or so people to do just exactly that. And it's a real smart question. One of the things that we've come to realize is that certain populations, particularly older people, don't do well with websites and may not log on to websites and push on links but they usually can find phone numbers. So it's really important that we have access, and we do have that kind of access through our phone bank. It sounds like from your question that maybe we need to promote it better or differently.
If I may, can I just ask what that number is? I'd love to have that available for constituents.
I don't have it in front of me. If I may ask one of my people in the other room, Phil Griffin, the immunization program, or colleagues, do you have that phone number?
Yeah, I can get it.
Okay, that's Ashley Jones-Weisner. We'll get it to you before we sign off.
1-866-534-3463.
Would you repeat that one more time, Ashley?
866-534-3463.
346.
866-534-3463. And if you also go to our ks.gov website, there's a button where you can email your question. Great. Thank you so much, Dr. Norman, and thank you, Madam Chair.
Representative Ballard.
Thank you. Dr. Norman, you mentioned the CPESN.
Yes.
Are you saying that they are mostly in our smaller areas geographically around the state, rural areas, or you said little guys, but little guys didn't tell me much.
I do know that rural communities that don't have a larger one oftentimes will have one of the smaller independent pharmacies. Madam Chair, with your permission, I'll ask Phil Griffin to comment on that. He's the one that did the negotiating of our portfolio of pharmacies, including with that one, and we've dealt a lot with them already. So if that's okay with you, Madam Chair, I'll ask Phil to comment.
Yes, that's fine. Thank you.
Thank you. This is Phil Griffin, I'm the Director of the Bureau of Disease Control and Prevention at KDHE.
Phil, can you get closer to a mic?
Is that better?
That's good.
Okay. Phil Griffin, Kansas Department of Health and Environment, Bureau of Disease Control and Prevention Director. CPESN is a network of local pharmacies, and they are scattered throughout the state. There's actually 3 or 4 different networks that work within the state. So they have pharmacies in both rural and the more urban areas. The project he's talking about, they were receiving some Pfizer vaccine this week, and actually that went to pharmacies in Arkansas City, Heston, Chanute, Kansas City, and one other right around Wichita. I can't remember exactly which one that was, but that's where those 5 trays went this week.
Thank you, Madam Chair.
Representative Ruiz.
Thank you, Madam Chair. Dr. Lee Norman, thank you again so much. I've been at several committee meetings where you have presented, and your information is always awesome. I was wanting to ask a question about the Social Vulnerability Index and how just looking at the map, and it looks like the darker colored counties, where is that where the higher vulnerability is? On the map with all the blue shades?
I think that you're looking at, ma'am, might have been the counties that have received the highest number of doses. But let me ask, if I may, Madam Chair, if Phil, I think Phil is the one that's most steeped into this social vulnerability index, because it's an important consideration, not only for where we allocate, but how we find populations of people that may not be easy to reach.
Yes.
If that's okay with you, Madam Chair. Phil?
Yes, you may proceed.
The vulnerability index takes into account a variety of different measures, including race and ethnicity, vulnerable populations based on economic factors, poverty levels, and those with greatest health risk. So the map that you were looking at is the one, as Dr. Norman described, is where the largest numbers of vaccine have gone. But those most vulnerable counties have a different makeup. For instance, Geary County, Ford County, Finney County, Wyandotte County are all a variety of those that have a higher social vulnerability index than many of the other counties.
Well, Madam Chair, can I have another question?
You may.
Okay. Dr. Lee Norman, so in my head, we've got the social vulnerability index, but we also know that, well, I don't know if we know, in my mind, we know that the counties with the highest populations, seems to me that maybe some of the death rates are a little higher there, especially among minority populations. Is there any truth to that, to me saying that? And the reason I'm asking that is it possible to shift the vaccine distribution to the highest populated counties within the state, hoping to be able to get to as many of those vulnerable populations, especially people of color, and have vaccines there? Because also in the higher populated counties is you've got population, you have higher density in these counties, and I mean, is it possible to make a shift that way? I know I'm asking a lot, but
No, you're right on target with kind of where we are right now, and actually have been for a while. And that is, one, there's no single distribution strategy that covers everybody well, the ones that are easy to get to, the ones that are hard to get to. You throw in kind of cultural barriers as well. Some cultures and races of individuals are more willing to be vaccinated than others are. We also know that, as you point out, that population density is also density of living quarters, multiple family generations living in one household. That's a different kind of population as well. And if you depend on people coming to a single vaccinating site, and I will tell you around the country, the states that look the best are ones that have had highly regional, maybe 5 vaccinating locations, and they expect people to get to those 5 vaccinating locations. That doesn't work for the populations that you're talking about. We have trailers that we've bought with federal monies that have come to us. We're working with, and just I know the governor met with Hy-Vee today, talking about, because they have Hy-Vee has a long track record of doing flu immunizations by going out to exactly the communities you're talking about. County health departments, again, do some of the, I won't say necessarily door-to-door canvassing, but very much bringing it to the people where they are. It's a little bit like what we're doing with the testing strategies, is that we've been recruited in churches, for example, to be testing locations. And the same things are planned. I wish we had enough vaccine to make it into an efficient outreach, but that's exactly what we're doing. And we're working with the various commissions that you know, and the Quad Caucus and others, to make sure that we don't forget anybody. I personally think, this is Lee Norman's opinion, but I think that one of the populations that we're having the hardest time with is older people who are independently living, maybe by themselves or with a husband or wife, but they themselves are not very mobile. They're not very adept at the internet, and they might not have a strong social support. They might have a pharmacist that mails them stuff, their drug or something. They maybe get to church, maybe not. I worry a lot about those, and that's true of all different ethnicities and races.
Sure.
So the bottom line is, it's going to take a lot of customization to not have anybody forgotten, and that is our goal, is to not have anybody forgotten.
Yeah, I appreciate what you're saying. I'm helping to get a testing site here in District 23, and I represent District 23 is in Shawnee, Lenexa, and Nolan Park. And if you look at the corner of Quivira and 75th Street, which is basically where I live, there are an abundance amount of apartments that are all clustered together. And so this is why we're trying to get a testing site done here. And of course, a vaccine site would be phenomenal, because District 20, without having our current census, but there are so many ethnic groups, and I don't know how many languages that are spoken just within this little area. So it'd be a great place to be able to have a vaccine site. We'll have a testing site here pretty soon in March. And so, yeah, I'm just kind of thinking about, if people of color are more vulnerable to the virus, and then have maybe dying from the virus. If it seems to me that then shifting the distribution to where these pockets are would make sense too. So
yeah,
just wanted to throw that in there.
No, you're spot on. When you look at the deaths, it's been older people and mostly white people. The per capita death rates for Blacks is higher and lower for Hispanic Latinos, but whites have accounted, and people over the age of 65 have been, I think, 3,700 people out of the 4,000 plus that have died. But that's because the Caucasians, older folks, tend to congregate more in skilled nursing facilities. So we have to act with every population differently, and we've tried to listen, but not just listen, but involve and collaborate, because it's not about the state agency, and it's really not even about the county health department pushing. We have to collaborate ourselves into having the right customized approach.
Madam Chair, please, one more comment.
Do you mind?
Okay, thank you, Madam Chair. the other thing I wanted to say, boy, I was just trying to get in my head what it was that okay. So the Quad Caucus, we've been looking at all of the data that KDHE is putting together, and it's awesome data. But one of the things that we're seeing is that, the trying to remove race in some sense, because if you would ask me what my race is, I would say white, because I don't fall in any of the other races.
Mhm.
And then I have to look at ethnicity in order to separate myself from the white race. I think that is kind of skewing the data when it looks like there are so many whites that are dying. I think there's a lot of Hispanics, Latinos that are in that population that we've not separated.
Absolutely. Well, and we do separate race. We recognize that Hispanic Latino is not a race. It's an ethnic group. But there's a large group that don't fill that out. So we have.
And there's that other.
Yeah, that's other. And that
Yeah.
other, and my belief, and research bears this out, that other, it tends to be more often Hispanic and Latinos and maybe
Yes.
mixed race persons. It's a very simple question, but a lot of people don't fill it out. And also, people are suspicious of if they check a box, or if they say what, they're worried that if they're, that somebody's going to, and call it what it is. If somebody is not here legally, they are concerned about putting out too much information. We're going to immunize them no matter what. No, it's about the illness. And yet it muddies the water on the data. So we're trying our best to look through that. We recognize that, that Hispanic and Latino is not a race, and but we have to keep track.
Sure. Thank you so much for all of your responses. Thank you, Madam Chair.
Representative Concanon.
Thank you, Madam Chair. Thanks for your presentation, Dr. Norman. I have a few questions. As you know, I'm rural and have 3.5 counties, and so my questions today are having to do with when the vaccines are in the county. And I know that that's probably not your responsibility, but I want to be able to answer some questions to my rural constituents. So a priority has been given to teachers. Are they in that category of high contact critical workers?
Yes.
So they're in phase 2, which is now.
Yes, that's exactly right.
So when vaccines arrive, and who makes that decision of who gets them and who doesn't? Is it just strictly the county health officer?
Good question, Representative Concanon. I could give you one answer, but I think that a more thorough answer would come from Phil Griffin, because he's the one that works closest on exactly this question. So, Madam Chair, I see. Did you hand the baton off to Mr. Chairman? No. Okay.
No, not yet.
She's in charge.
She's here.
Okay, Madam Chair, may I ask Phil to answer Representative Concanon's question on
Absolutely.
direction?
Yes,
yeah. Phil.
Sure. So what we're doing is we allocate the doses to the county, and the county health departments have it's been a project, it's part of their preparedness activities that they've been working on for years, that they are to work with community partners in identifying where and who can assist them in getting vaccines out. The prioritization within the phases, which I think is really what this question is getting at, is left up to the counties to determine on their own. Some counties, Sedgwick County is a good example of one that started with ages 90 and above and began to work down theirs because they had such a large population. And so they've broken it down as they reached limits of people responding there. Johnson County went a multi-pronged approach and worked with some different providers to right from the beginning start vaccinating childcare workers and educators as part of their overall plan while they were also vaccinating age groups. Finney County has done some similar things where they have targeted the teachers in one time and some law enforcement in other times and things like that. So it is left up to the counties to make some determinations. Some of the smaller counties have pretty much just kind of opened up to anyone who meets those criteria within phase 2, while others have been more restrictive to strictly looking at an age first and then going into others. Ford County right now is allocating part of their vaccine every week to some of the meatpacking plants there, while addressing others with other parts of their community partners. So it really varies by county, and they do have that prerogative. With the most recent request from the governor to prioritize teachers, we're finding that many of the counties have already done that, and others are shifting to at least a portion of their vaccine going to those groups right now.
Okay, and Madam Chair, are the independent pharmacies that have received vaccines, is that the same thing for them?
No, they've been given very specific guidance from the state, and it has been 65-year-olds and older. Have expanded it now that we're getting more vaccine in to include K through 12 educators as well, and staff. Yeah.
Okay, so that's kind of where I'm getting at with all of this. They can give to teachers.
Yes, I better ask Phil. He's the one closest to this. Is that at every one of those community pharmacies, Phil, that's included in the CPESN that has that same guidance?
Effective today, the retail pharmacy program has been expanded to teachers. There were exceptions being made last week when the extra vaccine came in, but when we updated for this week, it's 65 and above, all essential workers 65 and above, and teachers.
Okay, and I hate to keep beating on this drum, but does that mean that do those independent pharmacies have to have the permission of the county health officers to vaccinate teachers?
No.
Thank you.
They have that direction now. As of today, it's open for them to be able to vaccinate teachers without an exception.
Thank you. Thank you, Madam Chair.
Representative Ballard.
Thank you, Madam Chair. In just talking, I have another question. We have seen on TV and heard that let's just say they allocated 300 vaccines that they can give that day. And say it's 65 or whatever that target population is. And for some reason, only 250 show up. Now, is there a time limit on some of them, like Pfizer? You have to use them at a certain, what happens then if you think that's going to spoil? What kind of directions will the medics that are working, giving shots that day, what will they do with that vaccine?
Yes, that's a real good question. Well, one, they won't waste it. And if there's not enough demand for it, they have a number of days, as long as it's handled properly, in order to be able to give that. And they will expand it to other people in the same phase. Representative Ballard, do you want to know exactly the number of days or amount of hours they have in order to reallocate it to a different person?
I think the number of hours, because that's a question that I heard this weekend.
Right. Madam Chair, if I may ask Phil to comment on that, this is the world that he lives in as the, Phil, if please.
Sure. So Pfizer vaccine, once it's moved from the ultra cold stage to non-frozen stage, an unopened vial is good for 120 hours or 5 days. Once the vial has been punctured, it has to be used within 6 hours. Moderna vaccine can go from the standard frozen state to refrigerated state and can stay in that as an unopened vial for 30 days. Once the vial has been punctured, it also is to be used within 6 hours. So to get to this question, at the end of a vaccination clinic day, if they have a vial that has been punctured and needs to be used, and there's 2 or 3 doses left in that vial or whatever, what our instruction has been is to first and foremost, make best effort to address someone else in that phase that you're currently working in. If that is not possible and best effort has been made, then that vaccine should go into somebody's arm before it spoils. So that could be anybody that you can get a hold of immediately before you leave that day and get that vaccine into their arm. So in those cases, it does get out of phase, but it's in the avoidance of wasting a dose of vaccine.
Oh, thank you so much. I was hoping you would answer it that way because, I mean, if they're not available, I'm sure we all remember the one that they were along the side of the road and it was snowing and they went from car to car just to see if they could get rid of it. And some people didn't want it, but they found enough people. But if you have your target population, they're not there, and you have this 6-hour window, that's what I was wondering, because I didn't know the hours. I see 120 hours or 5 days or the 6 hours at once the vial is punctured. Then you would just give it to whomever you could find that would be interested in it. Is that what I hear you saying?
That's what you hear me say. Go to the nearest street corner and stick it in somebody's arm.
All right. Well, you know what? I guessed yesterday and I told him I thought that's what it was. And after I so boldly said, oh, yeah, that's what they do, I said, I'm going to ask. So now I can call tonight and say I made a correct assumption. So thank you very, very much. And again, I thank you very much for a nice presentation.
Thank you, ma'am.
Committee, any other questions? I have one. You mentioned on slide 15 that the vaccine might not stop the transmission of the virus to others. Is that pretty true of other vaccines?
It's true that the vaccine may not necessarily prevent an infection in somebody. It generally does. That's why they are so successful. But if it doesn't prevent somebody from either being colonized or infected with a virus, then still theoretically can result in transmission. That's why until we get more information over time, we want to see if there's transmission, if we can track through contact tracing to see if there's been a spread from somebody who has had the virus. I think it's going to end up being very, very low because the vaccines are so successful.
Okay,
Time
thank
will
you.
tell.
Any
Time will
others?
tell. It's the bottom line.
Representative Vaughn.
Thank you, Madam Chair. I just remembered, I know we have a couple of cases of the variant in Kansas. I was just wondering if you had an update on that as well.
Oh, goody. Science.
Thank you.
I'm sorry, I didn't mean to go out of order. Yes. We've doubled our testing platform so that we can do about 350 of the whole genomic sequencing tests per week, which, by the way, on a per capita basis is one of the real state leaders in all the United States. We last week, for example, did about 300 genomic sequences. That's the one that tells us if it's the B117 UK variant 1351 or the Brazilian variant. We've only had 2 so far, one in Ellis County, a young man, and interestingly, and I think you'll find this interesting, he was diagnosed with COVID-19 and the UK variant and was asymptomatic. He was an athlete, a college athlete, and was picked up as part of the routine athletic screening program that they put in place. Second one was from Sedgwick County, same variant, B117, and there was no link between the 2 cases from Sedgwick and Ellis. Ellis was an interesting one. We sent a strike team in there over the next couple of days, tested right at about 200 community members and contacts. And of the 200, unless that number's changed, Phil, I think only one person out of those 193 that we tested in Ellis County came back positive for the virus, and that one was not positive for the UK variant virus. So in summary, we have not had very much penetration. I saw that New York now has had the South African strain pop up in New York. We're hoping that those three don't become the dominant strain because they do appear to be more infectious.
That was all great info. Thank you, Dr. Norman, and thank you, Madam Chair.
All right, Chairman Carpenter.
Well, first thing I might say to the secretary is don't get too big a head from these girls saying you're doing a good job. So don't do that. But my question is, with these isolated cases and stuff, is there really a possibility that those have been here all along and we just have not caught them and tested for them?
Yeah, that's a sophisticated question, sir. Thank you for asking it, even though you were somewhat of a cheeky introduction. I will say that, yeah, I think you're right, Representative Carpenter, that it's been here. It's, anytime you're testing 300 people a week and there's, 5,000 cases that are diagnosed and probably that many more that go undiagnosed, then it's probably a little bit more common out there than what our numbers suggest. But it's exactly why we wanted to increase not only our state lab capability, but the commercial labs are gearing up so that we can do that kind of routine testing more commonly, more often. But I do believe that there's more of it out there than what we're picking up, yes.
Very good, thank you. You did a good job.
Jeez. Oh, I should have muted.
Oh, am I permitted? Oh, ma'am. Yes, I was looking at
Representative
that.
Ballard.
Thank you. I just had another question. I'm so glad he gave you a nice compliment, but let me just ask another question that came up yesterday. Do we know if men or women are responding better to the vaccine or how they react to COVID?
We have all that for the state of Kansas. We know all those demographics. If Representative Ballard, if you're asking me the science or the epidemiology as to those, I don't know the answer to that. I don't think there's a big gender difference between the B cell and T cell immune response. That's i.e. the immunity. Let me, if I may, Madam Chair, ask Phil, have you seen anything recently about that, Phil, about gender response?
No, not as far as an immune response or anything like that. Representative, are you asking about, when you say response, are you talking about the biological response or are you talking about response as in accepting the vaccine?
Biological response.
Okay. No, I haven't seen anything of variance.
What about the other?
What was part two, ma'am? Part two of the question.
No, he asked me, was it a bio response or was it to the accent? I just wanted to know because he asked those two, I thought I better ask about the other.
Yeah, we do have a higher rate of females being vaccinated than we do males. Now that can be skewed somewhat by the fact that initially in phase one, obviously it was healthcare workers, which is a higher female predominant workforce, as well as long-term care, which has a higher number of females living longer lives than males. So that could have some impact on it. But as we moved into phase two, we kind of continue to see a little bit of that same structure in that there are more females, and that's being seen nationally. And that also goes back, I think, to the general understanding that females tend to seek out preventative care at a higher rate than males do.
That might have been, Madam Chair, that might have been what the question they were asking me because they had heard that. But thank you very much, and thank you, Madam Chair.
Committee, anyone else? Representative Kincannon.
Almost forgot this one. Mr. Secretary, we had some legislators and staff that were vaccinated and have their second one coming up, and they don't know when and where to go? Are they going to receive an email about that? Do you know?
I'm going to ask Phil that you're talking about just the logistics of that one. When I got the vaccine, I had to, through the same process y'all were talking about, I had to set up at the same time. Phil, would you talk about the scheduling? Because I understand the question, yeah.
Sure. There will be an email coming from the team that is managing that. They have moved out to the Historical Museum. So that's where they will return for those boost doses, will be at the Historical Museum instead of the Armory. And those will be 3 weeks after the initial prime doses were done. So I'm thinking that that's like week after next, or next week, maybe next week. So you should be getting a notice.
First week of March.
It's a really slick scheduling program, I have to say, to do that.
Okay, thank you.
Committee, anything else? Well, thank you, Secretary Norman, for joining us today. Thank you for all the information. Really appreciate it.
Thank you for the opportunity to have my staff and me do this. Appreciate it a lot.
Mr. Chair? All right, well, it looks like tomorrow we have recommendations for DCF. So if you have those, make sure you bring them with you. And I guess with that, committee, we're adjourned.